Hello, everyone, and welcome to Using Data and Information Systems in Partnered Research, a cyber seminar series hosted by VIREC, the VA Information Resource Center. Thank you to CIDR for providing promotional and technical support. On the next slide, you can see that this series focuses on VA data use in both quality improvement and operations research partnerships. This includes query projects and partnered evaluation initiatives. This series is held on the third Tuesday of every month at 12 p.m. Eastern. You can find more information about this series and other VIREC cyber seminars on VIREC's website, and you can catch up on previous sessions on HSR&D's VIREC Cyber Seminar Archive. Next slide. This is a quick reminder for those of you just joining us. The slides are available for download. This is a screenshot of the sample email you should have received today before the session. On it, you'll find a link to download the slides. Next slide, please. Today's presentation is titled Evaluation of TeleWound I messed up with others. This is the download slide. And again, you can see the link on this slide. And next slide, please. Today's presentation is titled Evaluation of the TeleWound Practice Program, Working with Multiple Operational Partners, presented by Dr. Frances Weaver, Dr. Bella Etingen, and Marissa Worth. Dr. Frances Weaver is a research career scientist with the Center of Innovation for Complex Chronic Healthcare, CINCH, and a professor in the Parkinson School of Health Science and Public Health, Loyola University. She, along with Dr. Etingen, are co-principal investigators of the TeleWound Practice Program. Dr. Bella Etingen is a research health scientist with CINCH, and Marissa Worth is a research health science specialist with CINCH and project manager for this evaluation. Thank you so much for joining us today.
Hi, everyone. Oops, sorry, go ahead.
Nope, you go.
I was just going to thank everybody as well for joining us today. And you all know that just to get us started, so we can get to know our audience a little bit better, we're just going to do a few brief polling questions. Amanda, do you want to take it over?
Absolutely. So our first poll question on the next slide is, what is your primary research role? Investigator, investigator, PI, COI, statistician, data manager, analyst, or programmer, project coordinator, or other. For other, please use the chat function to describe what those others are. And the poll is open.
And so the poll is open, and answers are still coming in. We'll just give it a few more seconds for it to slow down, and then I'll go ahead and close the poll and share the results. All right, seems this thing has slowed down, so I'll go ahead and close the poll. And our results are, for those who said investigator, PI, COI, it was 30%. 7% says statistician, data manager, analyst, or programmer. 26% said project coordinator. 33% said other. And in the others, there are health policy, qualitative researcher. And back to you.
Great. Thank you so much. And our next poll is, how many years of experience do you have working with VA data? None. I'm brand new to this. 1 year or less. More than 1, less than 3. At least 3, or less than 7. At least 7, less than 10, or 10 years or more.
All right, so answers are coming in. We have a few people who have not started yet, so we'll let that run for a few more seconds. Please remember to hit submit once you select your choice. All right, so it seems that things have slowed down, so I'm going to go ahead and close the poll. And the results are 13% said none, I'm brand new to this. 4% said 1 year or less. 6% said more than 1, less than 3 years. 9% said at least 3, less than 7 years. 11% said at least 7, less than 10 years. And 10 or more years is 15%. And there was no answer from 43%. So back to you, Amanda.
Great. And one last question. A pretty simple one. Have you had experience working with multiple operations partners on a project? Yes or no?
All right. So seems like the answers have slowed down. The answers coming in have slowed down. So I'm going to go ahead and close the poll and share the results. And the results are 49% said yes and 12% said no. And back to you. Ella, are you speaking right now? I think you're muted.
Ooh, sorry. Yes, thank you, Amanda and Whitney. So just as a brief overview, in today's session, we are going to be discussing our partnership with multiple national stakeholders, our ongoing efforts to evaluate the implementation of the TeleWound practice program, developing a toolkit to support TeleWound implementation, the administrative data elements that we're working with as part of our evaluation, as well as how TeleWound encounters are coded across the VHA. So to get us started, just a little bit about operational partners and national stakeholders. The TeleWound practice program is a coordinated effort within VA to integrate telehealth into wound care services. TeleWound care can include both asynchronous encounters, which would entail taking a picture of a patient's wound and sending it to a wound care specialist for review. It's often referred to as store and forward telehealth. Or synchronous encounters, which are real-time video visits where the patient is either in their home or VA community-based outpatient clinic and has a video visit with a wound care specialist who's sitting at a main VA hospital. Importantly, the TeleWound practice program encompasses standardized training for VA care team members, standardized clinical documentation, and a strong emphasis on interprofessional collaboration and multidisciplinary care. The VA's TeleWound practice program started out as a grassroots effort at a VA medical center that serves a large number of veterans who live in rural or highly rural areas. The program was very successful at this facility, decreased travel burden related to wound care for veterans, and was met with high levels of satisfaction among veterans who received TeleWound care. Because of this early and encouraging success, the TeleWound practice program was selected by VA for larger scale rollout, beginning with regional level implementation and with a vision toward eventual national level implementation. The partnered evaluation initiatives that we are presenting on today focus on evaluating the regional level implementation of the TeleWound practice program. Our PEI has several operational partners. Our primary partner is the Diffusion of Excellence Office, and we are also working with the Office of Nursing Services, the National Podiatry Office, the Office of Connected Care, and the Spinal Cord Injuries and Disorders National Program Office. So now I'll just talk a little bit about the initial implementation of the TeleWound practice program and our PEI activities. The regional implementation of the TeleWound practice program has leveraged a multi-component facilitation-based implementation strategy, which has included identifying an implementation champion at each facility to support local rollout of the program, facilitating recurring virtual meetings, so think something akin to a learning collaborative here, to engage stakeholders, share lessons learned, and discuss strategies for overcoming barriers, and deploying standardized training to staff across facilities. As I mentioned earlier, the main goal of our PEI is to evaluate this regional level implementation of the telewound practice program. To accomplish this, we have 3 aims. The first is focused on evaluating the implementation process. The second is focused on assessing the impact of the telewound practice program on clinical outcomes related to wound care. And the third is focused on assessing its impact on healthcare system outcomes related to wound care. Data collection strategies we're using include surveys, semi-structured interviews with VA healthcare team members and veterans, and VA administrative databases, which we will go into in more detail later in the presentation. Findings from our evaluation will be used to inform further rollout of the telewound practice program nationally. And now I'll turn it over to Marissa to talk about one of our PEI activities, developing a toolkit for telewound implementation.
Thank you, Bella. So as Bella said, I'll be now talking about the toolkit development. So as we began the evaluation, it became clear that although there were several tools and materials created to facilitate telewound program implementation, there was a need for a more systematic, organized, and easily accessible summary in the form of a toolkit. Toolkits for implementation and quality improvement include collection of resources and tools designed to facilitate and adopt evidence-based programs. And we use this methodology for the creation of the TeleWound Toolkit, which can help facilitate the national telewound effort, No Wound Left Behind. So for the development of this toolkit, we use the Registered Nurses Association of Ontario, or the RNAO guide. Now, this is a professional association representing nurses who develop steps designed to assist healthcare settings in maximizing best practices through systematic and well-planned implementation through toolkit development. The original guide identified 12 steps. However, we will focus on the 6 steps listed. Step 1 is identifying evidence and guidance for implementation. Several tools, policy documents, and other materials have already been created for the telewound program. And we started by summarizing these documents to get an understanding of what has been previously developed. And we also developed a logic model. A logic model is a conceptual map of a project's efforts. Our logic model is broken down into 5 sections. The first part is to develop the goal or purpose. Next are inputs or resources. This includes things such as staff, training, patient or provider education. Next is processes. This section lays out the telewound program. This includes telewound modalities and the formation of a CHAR 4 code. The output section is looking at what evidence can be assessed to indicate the processes were performed as planned, or in other words, how do we know the telewound program was being utilized? And this can be done by looking at different data sources. Dr. Weaver will be talking about the processes and outputs in more detail later in this presentation. The last section of the logic model is the outcome section. This is the impacts or changes that came about as a direct or indirect effect of the telewound program. Now, going back to the steps of developing a toolkit, step 2 is engaging stakeholders. We utilized a portion of the biweekly national telewound meetings to introduce the project, review toolkit progress, and solicit input on various aspects of the toolkit. Our interactions during these meetings led us to be invited to different developmental meetings, such as the creation of the education modules. Step 3 is the developing stakeholder strategies. For our larger evaluation of the telewound program, we conducted check-ins with implementation sites. And during these check-ins, we asked them to identify what information or tools they wanted or may have developed at their own site. And through these conversations, we identified gaps in the startup, continuation, and buy-in of the program at their facility. These gaps are addressed with input from the national stakeholders. This step also includes looking at the use of supplemental technologies such as 3D cameras. Step 4 is determining environmental readiness. The creator of the telewound program, Dr. Bahar Astani, created a pre-implementation readiness tool, including questions regarding staffing, equipment, and local support. We updated and provided instructions on how to use this tool and how to interpret and act on these results. Step 5 is the evaluation plan. In the toolkit, we had made suggestions as to how the toolkit could be used to monitor progress, including tracking downloads and requests for material, monitoring telewound visits, and other strategies. And the last step, step 6, is identifying resources required. We laid out the resources needed to successfully implement the telewound program, including previously developed materials and newly added resources that filled knowledge gaps. Once assembled, we will ask our stakeholders to review the toolkit and refine it based on their feedback. And also during these ongoing interactions with the national work group, we were able to collaborate and determine a location to house the toolkit on the newly developed TeleWound website. Once finalized, the toolkit will be disseminated using strategies, including newsletters, emails, and cyber seminars targeting VA wound care providers and telehealth coordinators. Next, Dr. Weaver will be talking to you about the data elements of the TeleWound evaluation.
Hi, Dr. Weaver. Can you unmute yourself, please?
I was unmuted. Can you hear me now?
Yes, we can.
Okay, terrific. Thank you. Okay. Having trouble advancing the slides.
So if you could just click onto the slides and then just spacebar to move it.
There we go. Apologies for being technology challenged. So we use mixed methods to evaluate the implementation of the TeleWound practice at 4 VAs in VISN 15. Our primary data collection included surveys of veterans who had received TeleWound practice care regarding their experiences, satisfaction, and quality of life related to their wound care as a result of receiving the wound care practice. We are also following up with a small number of veterans who have volunteered to talk with us in more detail about their experiences by telephone. These interviews will be transcribed and coded to identify themes related to the TeleWound program. We had also planned to survey providers and staff regarding their involvement with the TeleWound program at each site and follow up with a few volunteers for more details by telephone, similar to our approach with veterans. But the number of individuals involved in the program at each site is much smaller than we anticipated, so instead we are considering conducting the surveys over the telephone and integrating some of the open-ended interview questions in our discussions. We also do a quarterly implementation check with our TeleWound practice liaisons at each site to monitor how the implementation is going, what is working, what barriers they have encountered, and any other information that would be relevant to the evaluation. Lastly, we had planned to conduct site visits at 2 of our facilities to see in person how the TeleWound practice program worked. But obviously, due to COVID, we have not been able to travel, and although we considered virtual site visits, we did not think that this would work beyond what we could learn from our interviews. So unfortunately, we will not be able to visit our sites. Other sources of data draw on the clinical administrative data. We are using the corporate data warehouse to track information about the TeleWound practice program, such as the number of visits, the types of telehealth being used, and the types of wounds treated. And then we will also be looking at utilization associated with wounds for these patients, such as were they hospitalized, did they experience an amputation as a result of their wound, or did they die? We will also compare these data to a sample of facilities and patients with similar wounds who did not receive TeleWound practice. We are particularly interested in tracking telehealth visits since this is a telehealth program that we are evaluating. These visits are not as straightforward as they might appear. For example, some telehealth events consist of 2 encounters, one on the patient side and another on the provider side. For example, a veteran may have a store and forward visit in which an image is taken of the wound at a CBOC, and then that image is sent to the wound care provider at a VAMC who reviews the wound and recommends treatment. These are entered as 2 visits for workload credit purposes, one for the CBOC and one for the provider who reviews the images. But it is only one TeleWound practice encounter for the veteran. Other telehealth visits are a single counter, such as a virtual visit in the home where the provider is communicating in real time with the patient. In this table, you will see a list of primary and secondary stop codes for a clinic visit. This table was specifically created for wound care encounters, with the most likely visits that would provide wound care listed under the primary care column, and then the secondary column identifying the type of telehealth visit that was provided. A primary care clinic is a service or program that provides the care. For example, infectious disease or podiatry. If you look at this list, only one of the clinics, stop code 142 for wound and ostomy care, would tell you that the care is for a wound based on the primary stop code. The secondary codes would then tell you about the type of telehealth. Only one of the codes in the primary care column will tell you if the care is for telehealth, and that is stop code 225 for spinal cord injury, SCI telehealth. So if you were just to rely on the primary stop code, you would not know that the vast majority of these visits were for telehealth or for wound care. The secondary column is really for secondary stop code is really to tell you about the type of telehealth care that's being provided. For example, store and forward, clinical video telehealth, or virtual veteran care in the veteran's home. Details about how to code the TeleWound practice visits, including this table, are provided in the TeleWound specialty supplement developed in 2020, and that is available on VA's telehealth website. So, how do we go about coding telewound encounters? If you notice on the table, with one exception, there is nothing available in the codes that tells you that the visit was provided for wound care. You might think, well, I could look at the diagnosis code for the visit, and if the diagnosis is for a wound code, say a diabetic foot ulcer, then I will know that the visit was for wound care. This is not a reliable way to do this. Case in point, a veteran with a spinal cord injury could receive a virtual care visit for a pressure injury. Yet, when you look at the diagnoses, you see codes for spinal cord injury or paraplegia. There isn't a code listed for a pressure injury. And unfortunately, this happens quite a bit. So in that case, we would not know, relying just on the diagnoses, that that particular visit was for a pressure injury and not for something else. So let me introduce you to something called the CHAR4 code. This is a 4-character code that provides more detail about a clinic visit. These codes can be at a national level or a local level, or they can be a reserved code used specifically for a program or a service. These codes require justification and rationale for being created, and these justifications are reviewed and approved by the CHAR4 Council. In our case, because we did not have an easy way to identify whether our telehealth visits for the telewound practice were indeed for wound care, it was necessary for us to get a CHAR4 code. After some back and forth with the council, they did approve providing a CHAR4 code for telewound care. Before I talk about the specific code for telewound care, I wanted to show you a snapshot of the master list of CHAR4 codes that are available. I highlighted this national code for the disruptive behavior clinic. This is considered a reserved code, and it is specifically related to workplace violence prevention. And it was created very recently in March of 2020. And the actual code for this is listed in the first column, so the 4-character code. If you look at column C will tell you if this is a national code that was created, a reserved code, or in one case we have a local code here. You can see for 708, the NBLU code stands for Blue Team N, and that was a local code. If you look at column E, this will tell you when the code was created. Many of these CHAR4 codes were created before fiscal year 13, and a few more have been added since, some very recently. So that'll give you some sense of what CHAR4 codes look like. Okay. In our case, we were assigned a CHAR4 code for the TeleWound Practice Clinic, WCUC, a 4-character code, which we refer to as the WCA code. I think I've already explained why it was necessary to have this code, because a clinic visit would have 2 stops, a primary code and a secondary code. And if the first code tells us the service that's providing the care, such as infectious disease or spinal cord injury, and the second stop code tells you that it's for what type of telehealth it's for, such as store and forward or clinical video telehealth, we still don't know that that visit was for wound care. So by having the CHAR4 code available for use, we can now attribute those visits specifically to wound care managed through telehealth. Here is another screenshot this is information that we pull from our sites each month to identify who is receiving telewound care. We pull the data for primary and secondary stop codes based on the table that I showed you a few slides back. So the primary stop codes we're looking at include podiatry, primary care, wound care, and spinal cord injury. The secondary codes will be the codes for any type of telehealth. And then we also pull the national CHAR4 code to identify those cases where an entry for wound treatment, the WCUC or WCA code, is made available. If you look at our first line of data, this is a primary stop code 142 for wound care treatment and ostomy care. There is no secondary code, and there is no WCA code, no CHAR4 code at all entered. So in this case, we might assume that this particular visit was in person in the clinic for wound care. If you drop down to the next, to lines 4 and 5 that I've highlighted here, these are both primary stop codes for spinal cord injury telehealth care. On the first line, there is no secondary code telling us what type of telehealth was received. However, there is a CHAR4 code, the WCA code, telling us that this telehealth visit in spinal cord injury was for wound. So we can count that in our evaluation as being a wound care visit. We just don't know what type of telehealth was provided. On the second line, we have the same information that this is a spinal cord injury telehealth visit. Now, in the secondary code, there is a code for SF, store and forward care, telehealth care. And again, there is a CHAR4 code for wound care. In that case, this individual received a spinal cord injury telehealth visit that was store and forward for wound care. If you drop down to line 9, here's an example of primary code being infectious disease, and it was a telehealth visit. It was for clinical video telehealth, CVT, but there is no CHAR4 code listed here. So in this case, we don't know if this the 2 patients that received clinical video telehealth for infectious disease what the particular healthcare issue was that they received care for through telehealth, without going back and trying to piece that together with diagnostic information. We are assuming that our sites are using the TeleWound CHAR4 code for anything related to wound care. Okay, advance my slide here. We are also looking at other data sources for other information. Many of you are probably familiar with the PSSG codes. This is the planning office that tracks a lot of geographic information about our veterans. We are using the PSSG to calculate distance. So we will be able to calculate the distance between a veteran's home and the closest CBOC and the closest VA medical center. And this is actually one of our primary outcomes. We're looking at what effect providing wound care in the home has on travel burden for veterans. So we will be able to demonstrate how much time is saved and how much distance, and actually be able to calculate using mileage estimations how much could be saved by providing this care through telehealth. Two other sources of data that we've looked at. One is the VSSC, which provides real-time data. And this, we're looking at this for telehealth visits in order for TeleWound, in order to identify which patients have received this care in the past month so that we can send out surveys to them. And lastly, we took a look at something called V-Signals. This is from the Veterans Experience Office as part of the Voice of the Veterans, and I'll come back to that in a moment. So the TeleWound program can be identified on the VSSC telehealth dashboard. It includes information about workload, visits, clinic stops, clinic location, and encounter provider. You can drill down to a specific facility or clinic, look at information over time at the clinic, provider, or patient level. And you can also use it for benchmarking. So we can look at care before and after a particular program was introduced or some change was made. So we'll be able to look at this information over time. We were also very intrigued by another data source called V-Signals, or Voice of the Veteran. Voice of the Veteran comes from the Patient Experience Office. The Patient Experience Office is part of the larger VA, not the Veterans Health Administration, but the big VA, which includes benefits and cemetery and other components of the Veterans Affairs. In this case, the V-Signals is focused on the Veterans Health Administration, and it relates to evaluating experience with various components of VA's healthcare system. V-Signals is a brief web-based survey that can be completed on a computer or a smartphone. It requires that a veteran have an email registered in the VA database in which the VA can email them questions or information. Veterans are emailed after an appointment or encounter at a VA hospital, clinic, or if they received care in their home. And then V-Signals has a dashboard to be able to examine these results. We were very excited by the possibility of being able to use V-Signals as another source of data to evaluate implementation of the TeleWound practice program. This shows you the various domains that the V-Signals data collects in their brief email surveys. I won't go through this in detail, but you can see that the domains include the ease and simplicity of care, efficiency and speed, quality, helpfulness of employees, the equitability and transparency of the care, satisfaction, and confidence and trust. So we were hoping that this would be another source of information that we could utilize to evaluate the TeleWound program. In order to get access to the V-Signals dashboard, you need to request access. This can be granted through your VISN office. The V-Signals has drop-down menus for various services and care provided by VA, similar to the dashboard that the VSSC uses. If you were to look for the TeleWound program within V-Signals, you would have to look under the telehealth module and then select TeleWound in the char4 menu drop-down. And again, you can filter at multiple levels, similar to the VSSC, to get this information. And then you can get the patient experience scores for these various domains, whether they were surveyed about scheduling an appointment or receiving care in the home or a procedure. So all those different types of services are part of the survey. However, when we looked at the data for V-Signals for telewound care, it turned out that it's not something that we're going to be able to use, at least right now. So we looked at the data for fiscal year 2020, and we found that a little over 50 surveys were emailed to veterans who received the telewound practice care in fiscal year 2020. And only 4 people responded to the email survey, so a 7% response rate. So the good news is for the 4 people that completed the survey, their ratings are very high. In fact, on 4 out of 6 domains, it's 100%, and very close for the other 2 domains. Unfortunately, you can't really evaluate a program with 4 responses. We do believe that as the program grows, and as more people make their emails available for this kind of a survey, that we will see more people responding to the V-Signals. And in the future, this may be another source to evaluate programs like the telewound care practice. So I think that at this point, I'm going to kind of wrap up the presentation. I do want to acknowledge the team members for our telewound practice evaluation team, as well as some of our national partners, including Brian Stevenson and Devin Harrison from the Diffusion of Innovation Office, Dr. Mona Baharastani, who was the brainchild of the telewound program and won Shark Tank and got this program started, Shante McCoy-Jones from nursing, who has been very involved in this program, and Alicia Leisure from VISN 15. She is the telehealth coordinator for the VISN and was instrumental in getting our sites up and running early on in the evaluation. So I'm going to stop now, turn it back to Amanda and Whitney, and see if there are any questions. Thank you.
Thank you so much, Dr. Weaver. We do have a couple questions. As a reminder, you can type in your questions in the Q&A function. The first question we have is, what was the process of getting a char4 code created, and approximately how long did it take?
So the process involves an application, and that application requires justification for why you need a char4 code. It probably took about 4 months from when we first submitted the application, and it's the big we. It wasn't really the evaluation team that submitted it, although we were participating in it. It really was the various stakeholders and the Diffusion of Excellence Office that put the application together. I would say it took about 4 to 5 months because the initial justification came back and they wanted more details. So a little bit of back and forth. It took about, I want to say about 4 or 5 months.
Okay, great. And how did you ensure adoption and consistent use of the WCA code at the various sites?
Marissa, you want to take that one?
Yeah.
For the TeleWound supplement, which is the national stakeholders created for the national TeleWound implementation, it is listed in there that TeleWound does have the WCUC code for sites to use. So that was disseminated or made available a few months ago. But it is something that we're still working through. And for implementation sites, we're kind of asking them, did you know this existed, and trying to kind of get to the point of how they can figure out that it's there and they can then use it. So that is an issue that we're running into, but hopefully with maybe the toolkit coming when it becomes available and the use of the TeleWound website, people can go there and then see that you can use that to better identify those encounters.
Thank you. And what was done for process evaluation? You mentioned check-in at sites. Anything else? How was the information used? Was it used in refining the program?
Bella, you want to take that one?
Sure. So we are trying to iteratively feed back ongoing kind of early results to our partners so that they can use that information to make improvements as the program is implemented and the kind of, implementation is smoothed out. And then we will be submitting a final report to them as well. But yes, we're doing about approximately quarterly check-ins to try to get some of the early evaluation data back to our partners.
And do you think you might get better feedback if the evaluations are linked to the clinical encounters?
I believe they are. I don't quite understand the question.
If the person who asked the question wants to put a clarification in the chat.
Happy to answer
meaning that your evaluation is done at the time of the clinical encounter instead of afterwards.
It's difficult to do this in exact real time. We do provide feedback whenever we see anything in the data that raises any questions, and that occurs on a monthly basis. So it's not exactly in real time, but within a month of the encounter, if there's anything that raises any kind of question, we go back to the site to try and clarify what's going on.
And do you have any recommendations when working with operational partners?
It really is a partnership. They have great ideas in terms of what data to collect and how to collect it and how things will be received. And, so it really is a give and take. We share information with them. They provide feedback. They share documents with us, and we provide feedback. So currently the toolkit that Marissa talked about, we are getting input from the clinical side, and we'll modify the toolkit based on their feedback. So it really, when we talk about partnership, it really is.
And that somewhat addresses this issue, but can you talk about any pre-implementation work done with the partners or sites?
Before we began the evaluation, there was a kickoff meeting in Kansas City that Dr. Etingen and I attended. We were able to meet with a number of key individuals from each of the 4 facilities, as well as Dr. Baharastani, folks from the Diffusion of Excellence Office, to get to know each other and to identify any issues or barriers that they thought might be particularly important to address at their sites. The Diffusion of Innovation actually fielded an initial readiness for implementation survey for us, because at the time we were not ready or approved to do any kind of data collection. So they did that first round for us, and that information was very valuable to take a look at, to know what kind of information we should be tracking as part of our evaluation.
Great. On the next question, I am familiar with the efforts to adapt an evaluation tool called the BWAT into a tool called the SCI-PUMTT, which I'm sure pronounced some fancy way. By any chance, were either of these part of the clinician's toolkit?
I think that you are the individual is referring to something specific to pressure injuries, which is specific. That tool is specific to spinal cord injury. We had patients with many different types of wounds, not just pressure injuries. So we have diabetic foot ulcers, we have other leg ulcers, we have surgical wounds, we have osteomyelitis, cellulitis, so lots of different kinds of wounds. So using a tool that would be specific to one wound in one population would not be appropriate for this.
Okay, thank you so much. It looks like those are all of the questions. Any last wrap-up that you guys would like to add?
We have about 9 months left in our evaluation, and we are looking forward to getting additional information on our evaluation and being able to disseminate that perhaps a year from now. Thank you.
Thank you, and thank you so much to our presenters for taking the time to present today's session. To the audience, if you have any other questions for the presenters, you can contact them directly. And please join us for VIREC's next Using Data and Information Systems in Partnered Research on February 16th at 12 p.m. Eastern. Dr. Leslie Hausman and Dr. John Cashy, Dr. Ernest Moy will be here to present Leveraging VA Data and Partnerships to Advance Equity-Guided Improvement, an Introduction to the Primary Care Equity Dashboard. We hope to see you there, and have a wonderful day, everyone.